too much into statistics because statistics is not my strong point, and I'm slowly working through it myself. So if you have questions as we go along, you're very welcome to put them in the chat, and either myself or Theo can kind of see them, and then I'll keep the chat up in the corner, and then we can try and answer them as we go along. So I think the first thing to just remind yourselves of is what we kind of define as a systematic review. And it seems like a silly thing to say because we all know what it is, but the times that I struggle are the times where I've forgotten what I'm actually doing. And so I think I quite like this definition, where a systematic review attempts to collate all empirical evidence that fits the pre-specified eligibility criteria in order to answer a specific research question. And so the reason I like that part is because whenever you're doing these, when you're going through the process of a systematic review, when you start, you have a nice predefined question and it seems like a great idea and you have your methodology in your head. But as you're working through the project and you kind of get tired and you're triaging endless articles and you're looking at statistics and trying to assess bias and all this sort of stuff, you can forget to come back to that methodology and you can feel a bit lost and sometimes go down a bit of a rabbit hole and find yourself miles away from where you thought you needed to be. So always bring yourself back to the idea that you have one specific research question, you know the eligibility criteria for that, and you should hopefully have brought together all the evidence you need to have it there and then. And then the next part where it says it uses explicit systematic methods that are selected with a view to minimizing bias, thus providing more reliable findings from which conclusions can be drawn and decisions made. So systematic methodology is absolutely essential to a systematic review, and you should all write down your methodology and stick to it. So you should have it written down before you start your review, and all reviews should be registered on Prospero, which is the database run by the University of York that has all of the systematic review methodology registered on it. And you should really try and stick to it, and it allows you to kind of come back when you feel a bit lost or you're unsure about a question, go back to your methodology and stick to that. So I would always say have a kind of rough definition in your head that you can always come back to. So first question, which I thought was a really good question, and I've put it at the front because it's, for me, actually comes at the front. So the question was, is fieldwork part of a systematic review? Now, I took fieldwork here to mean kind of observing whatever you're looking at in its natural environment. So for example, if you were doing a systematic review of, I don't know, robotic surgery, for example, then do you need to go and look at some robotic surgery before you do your systematic review? Or do you need to look at things in the field, on the ground, before you do your systematic review? And the answer is no, in that there's no, you don't, strictly speaking, you don't have to prove that you have done. However, to do a good systematic review, you need to have a good, well-defined question. And we'll have all seen lots of systematic reviews out there of things that don't really matter to patients very much. There'll be systematic reviews of whether an anaesthetist has a pink or a green car and whether it makes a difference to their outcomes, for example. It's not really that relevant to the patient necessarily. So whilst you don't have to have it within the methodology as part of your systematic review, I actually think it's not a bad idea to go and talk to people who your systematic review will influence. So for example, if you were doing a systematic review looking at 2 different vaccines and comparing which vaccine was better for preventing a respiratory virus, for example, it would actually be worth going and spending time with the patients who have that virus, so you can then discuss and understand which outcomes are actually relevant to them. And that might then guide your systematic review to say, rather than which one is better, you say which one is better looking at this specific outcome. And then it becomes relevant to your patient population and becomes a worthwhile piece of research. And that's essentially patient and public involvement in research. Now, what I've done here is I've put up on the left-hand side, a little picture you can see. This is the National Institute for Health Research. They have an enormous patient and public involvement education kind of platform. And I would highly recommend you all go and have a look at it. They've got multiple resources for how you can involve your patients in your research more. The idea being that if you involve your patients more, you actually answer questions that are relative to them, and your impact is a much better, your research has a much better impact on them. And there's a QR code on the right, which you're very welcome to scan. But either way, I'll send these slides to Theo, who can circulate to everyone afterwards. So to summarize, strictly speaking, no, fieldwork is not part of a systematic review, but actually it's quite important to understand what's relevant to your patients, what makes a difference to them. So you can systematically review that rather than something else, basically. Next question was, how many online literature are supposed to be used for systematic review, if any are available? And is there a threshold number? And I used this to kind of answer two questions that were there. So one, the question of, is there a minimum number of databases that you need to search? And two, is there a minimum number of papers that you need for a systematic review? So in terms of databases, I would say you need a minimum of 2 databases, but ideally you need 3 or more. For a good systematic review, you need to be searching 3 databases or more. The ones I would always recommend are Embase, which is the slightly extended version of PubMed, okay? Or you could use PubMed as a replacement, and Medline. So Embase or PubMed and Medline will have pretty much everything that you'll ever need on your chosen subject, okay? And then Web of Science is a platform that will capture pretty much everything on these two, on Embase and Medline, and it will add on anything else that you might have missed or that might be on other resources elsewhere. So those are the 3 that I always use. And then I tend to have a look at Cochrane as well, just to make sure that there's nothing else out there that's already been done. And Cochrane can be quite useful because it will bring up protocols for other systematic reviews that haven't been done, or it will bring up other systematic reviews on your topic that have been done that can be quite useful. So those are the 3 that I use as a baseline. So Embase, Medline, and Web of Science. And then I always have a look at Cochrane and put the questions and my search terms into Cochrane to make sure I'm not missing anything. And then to come to the number of papers. So again, strictly speaking, there's no minimum number of papers that you require. As you go through your systematic review, you'll have your inclusion and exclusion criteria. And it may be that with your exclusion criteria, you only have 1 paper left at the end of it, okay? If that is the case, and you end up with very, very few papers, that probably means one of 2 or 3 things. Number 1, there may not be that much out there on your topic, and that's okay. It may be you're looking at a very niche or new technique, for example, and that's okay. That's an important finding in itself. It may be that your methodology is too restrictive. So it may be that you need to look at your eligibility criteria to make sure that you're not getting rid of lots of papers that would be useful. And that's where having a play around with your search terms can be quite useful. Or it may be that you've looked at something very specific. So for example, if you're looking at to do a systematic review of only randomized controlled trials, it may be that actually there's only 1 randomized controlled trial on your topic. And so your systematic review may not be able to provide any comparison unless you expand or relax your eligibility criteria and look at randomized trials and cohort studies, for example. So I would say that no, there's no minimum number of papers, but if you're getting very few, it's hard to make a comparison, and therefore you need to have a think about your about all the things that we've said. The only time that you must have 2 or more is if you're going to do a meta-analysis. If you're going to directly compare the 2, and you're going to do a meta-analysis, then you'll need at least 2 studies to do that with. Now, if you're getting to a point where you've got a very niche topic, or it's something that's very new that there's not much data out there on, or it's a very old topic, for example, but people haven't really adopted it, and there's only a few kind of small case kind of series in the literature, for example, one thing you can do is a systematic scoping review, okay? And the idea of a scoping review is just to bring together all of the literature on that topic. So it brings together all of the literature on a very niche topic and allows you to basically do more of an overview of that topic. And you still follow a systematic methodology. So you still develop your search terms, you still have an inclusion-exclusion criteria. And this is quite useful. So I'm sure you've all heard of PRISMA by now, which essentially are the guidelines that outline your methodology and the structure and the reporting standards that you have for a systematic review. They have an extension on there for scoping reviews, which is very, very useful. And again, I would have a read of that. So if you're looking at a very niche topic and you don't think there's going to be much evidence out there, it might be better for you to do a scoping review to bring together all of the literature rather than trying to do a formal systematic review with very few papers. So that's something to consider. So in summary, for your databases, ideally you want 3 or more, and those 3 for me would be Embase, Medline, and Web of Science. And then in terms of your minimum number of papers, you don't need a minimum number unless you're doing a meta-analysis. But if you're looking at a very niche topic or find that there are very few papers coming together, then you may want to do a scoping review instead. Move my screen. And this I thought was a very good question. So someone has asked, is there a possibility that the results of the same research topic will differ even if the same methodology was used? Now, strictly speaking, the answer is no. There shouldn't be a difference. If you've got the same methodology and you followed everything exactly, there should be no difference. However, everyone is different and we are all human, and therefore we all do things differently. So for example, if Theo and I were reading the same paper or we're doing the same kind of screening of abstracts, we might find that actually we both think differently about a different paper, and therefore one paper might be excluded compared to the other. And so you then might find that the final number of papers in your study is 1 fewer in mine or Theo's, and you therefore might find your results are different. And that's okay. So you therefore, to try and avoid that as much as possible, you need to have a very clear inclusion-exclusion criteria and a very clear structured methodology you set out before you start your systematic review. So that would always be my advice, is to minimize the results being different. You should always write out your methodology so someone else can follow your methodology. And part of developing that methodology is have a look at some other systematic reviews. Have a look at some of the reviews in the Lancet, in the New England Journal of Medicine, in those journals that are very strict on their criteria for publishing, because it means that the methodologies behind them are very good. And so if you read the systematic reviews and the meta-analyses in those journals, they have very, very good methodology. So that would be my advice on that one. This is another interesting question coming on towards the more outcomes and the stats side of things. So again, I've steered clear of the statistics, but there was a question that during the in the course, someone was talking about outcomes and the number of outcomes and how that might affect your results. If you are doing a systematic review and you are looking at one outcome, so the primary outcome of a trial, for example, so let's say you're looking at patients who have aspirin versus a placebo to reduce cardiovascular mortality. So mortality from cardiovascular cause at 1 year, okay, for example. So your single outcome would be mortality at 12 months. And if you were to do a systematic review of looking at all the different studies looking at aspirin versus placebo, you're only looking at one outcome. And that's quite easy because the studies are powered towards that outcome. And so there should be enough patients in each arm of the study to give you a significant difference if there is one there. So when you do your systematic review, you're looking at one outcome from well-done methodology. Things start to become tricky if trials, this is mainly in the setting of clinical trials, but if trials start using co-primary or composite outcomes, which is where you have more than one component to your primary outcome. For example, if they were using aspirin versus placebo to look at cardiovascular morbidity at 1 year, which may include death or heart attack or stroke, you might find that because you're looking at multiple things, there's a higher likelihood that one of those things is going to happen. And so if you're giving someone aspirin, you're probably going to reduce one of those things just by chance. And so it then means you have a study that comes out as positive in inverted commas. And so when you do your systematic review, you're looking at lots of studies that have a positive outcome, but actually their primary outcomes are slightly different. And so when you have a larger number of or more components to your primary outcome, it becomes harder to compare. And similarly with secondary outcomes, if you have studies that have lots and lots of secondary outcomes, there's a higher chance that they will find a significant result just by chance. So for example, let's say again, we use aspirin versus placebo, and the primary outcome is death at 12 months. And then they look at the secondary outcomes, and let's say, I don't know, the secondary outcome might be heart attacks, a number of heart attacks within a year, that's fine. If they have 4, 5, 6 things, and at the bottom they have something like nosebleeds, you might find that the patients who had aspirin had 5 nosebleeds compared to placebo patients who had none, okay? And that can be just by chance. It may not be related to the aspirin, we don't know, but they found it. And so if you then conclude from your study that aspirin causes nosebleeds and we shouldn't be using it for cardiovascular patients, that's a negative thing. So the more secondary outcomes you have, the higher chance of finding a difference just purely by chance. And so when you're looking at the bias of studies, it's better to be looking at those that have one single primary outcome and that have very few secondary or relevant secondary outcomes, so that actually what they are reporting is important and useful clinical stuff rather than things they've just found by chance. I hope that makes more sense. This is the only stats thing that I've touched on, and this is just merely a proof of principle type thing. So someone asked a good question of, is the forest plot the only means of meta-analysis presentation? The answer is no. It's the most commonly used one. It's the most common. So the forest plot up here on the top left. Again, you're welcome to take screenshots, pictures, but I'll send Theo these slides. So you can see here forest plots are the most probably the most widely used, and they've come in slightly later into so in the kind of more recent kind of half century really to people doing systematic reviews and meta-analyses. But it does depend on what your question is. So the way you present your data will depend on what your question is and what your outcome is, okay? So for example, you might use a funnel plot. So a funnel plot will allow you to look at, they're usually used for the effect seen in a study compared to specific characteristics of that study. So it's very good for presenting things like bias as part of a meta-analysis. So again, the greater you might have the increased risk of bias on the left-hand side and the effect size here, or the effect that you're seeing. And it's a very good way of looking at bias. So it all depends on the data that you are looking at. But I would say that for the most part, a forest plot is pretty good all of the time. But yeah, again, before you start your systematic review and meta-analysis, have a plan for how you're going to present your data. And depending on what data you're looking at, you can explore the different ways of potentially presenting that. This was another fantastic question. So this is kind of coming towards the end of the Q&As now. So once you've done all the hard work, what processes must you go through to publish this? And I have written the wrong thing in there. So I have to talk, so ignore this here. So what processes must you go through to publish this? So number one, you must follow the PRISMA guidelines. Again, I'm sure you've seen them all by now, but the PRISMA guidelines for systematic reviews and meta-analyses, again, there's a website, it's all free. It gives you a structured way of reporting. So it's the minimum reporting standards for a meta-analysis. So it gives you a step-by-step instructional guide for the things you must include to prove that the methodology of your systematic review is robust enough for you to draw the conclusions you have drawn. So that's how you get it published, is you make sure you've followed those guidelines. So the manuscript you write clearly outlines the methodology and the results. The other thing that I would say is important is look at which journal you're thinking of submitting it to, okay? And then follow their instructions for authors. So for example, if you look at the Lancet have very strict criteria for what they want as part of their systematic review. So they will say to you, have you followed the PRISMA guideline number 1? And you'll hopefully tick yes, because you should have written your paper in line with that. And then there will be other things that they want you to have done in order for them to publish your systematic review. So have a look at PRISMA guidelines and then the journal you're submitting to, and you write everything with those two things in mind, and you should be able to publish your systematic review. And then importantly, why have you done this? Well, the whole point of doing your systematic review is to answer a clinical question so that you can hopefully improve the care of your patients. And so then the question comes is, after you've done that, how do you implement the results to effect a change if necessary? And so this for me does depend on the results. So if you find at the end of your systematic review that there are lots of randomized controlled trials on a particular subject, and you've done a systematic review comparing technique A and technique B, and you find that the overwhelming evidence is that technique A is much better, then your systematic review has done its job. It's shown you which one is better. And then what you need to work out is how you're going to implement that. And I would start at a local level. So look at your own unit, look at your own practice and say, right, are we doing this or do we need to start doing this? And you'd basically present the way that it works for where I've seen these work before is you present them at a local meeting, discuss with the kind of the senior team and all of the team working with the patients and say, is this something that we have the facilities and the resources to do? And if yes, are we happy with the evidence? Do we think it's a good systematic review that's come out with the right answer? And can we start doing it in our unit? Now, it may be that you don't do it straight away. You only just say, well, what we'll do is for every 20 patients we see with this condition, we'll just have one patient who has this. And if we have, and we use this treatment for this patient. And if after several patients, you find that it is safe and you're getting good results, then you might increase the number of patients you use it for. Or it may be that it's something so good. For example, if you look at the COVID trials, if you look at the recovery trial for COVID, there was very good randomized evidence that various drugs were better for patients with COVID at differing stages. If someone then systematically reviews that and that confirms that the overwhelming evidence is that these are the drugs we should be using, then you can kind of crack on and use those drugs, for example. So a lot of it depends on your local unit and what your results show. However, sometimes you'll have a systematic review that says, well, we can't really find a difference between the two things we've looked at. And that may well be because there's not enough data out there. You may have found that actually you've got a very niche technique that's very early and there's not enough data out there. And so you need more data. And so you then have to decide as a unit, are you happy to start pioneering a particular technique and adding to the data and adding to the literature yourselves? Do you need more randomized controlled trials? Do you actually find that there's poor evidence or the bias of the trials you've looked at is too high and they're not really very reliable? Do you need to start a randomized controlled trial of your own? Sometimes there won't be a scope for a randomized controlled trial. For example, if you're looking at a particular operation and you say, well, one way of doing this is to do one operation and do 2 bits of surgery in one go. Or it might be that the other way to do it is to say, well, actually, we could do one operation on one day and one operation 6 months later. And you might say, well, looking at the literature, my systematic review says there's no difference between those 2 techniques. And you might think, right, well, I need to do a randomized controlled trial. Well, is it ethically right to put someone through one operation? Or is it ethically right to put them through 2 operations that you could have done in one? So you have to then think, well, there's probably not the scope for a randomized controlled trial. And so how can I interpret my systematic review? Well, it might be telling me actually that a particular patient population is better suited to option A rather than option B. So that's one way of implementing the systematic review. But I would always suggest that you look at the way you could implement it locally in your unit with the resources that you have available to you, with the patient population, because they have to be happy with the treatments you're proposing, and also with the kind of team you work with, are the team you work with happy to implement the results of your systematic review? And the other way to do it is there will be guidelines. So sometimes you'll do a systematic review and you'll find that people include it in guidelines and use it to make a convincing argument for treatment A over treatment B, and then everyone will start following those guidelines. So one of the more useful things to do is to have a journal club where once a week or every fortnight or every month, someone presents a paper and just kind of, it might be something new and exciting in the field that you work in, and it might include a systematic review, and you can discuss it as a unit at that meeting and then say, do we think we should be doing this moving forward? And so that's one way in which you can implement the results of a systematic review that you've done. You can present it at your departmental meeting or with your colleagues and say, what do you think? Are you happy for us to kind of take this forward? And that's all I really have for you this evening. So I kind of have tried to take you through a bit of the kind of basics of setting up with your methodology and the minimum requirements, right through to how you present your data and then how you actually interpret your systematic review at the end of it, which is the most useful part of it. I hope that's answered some of your questions. If anyone's got any other questions, I'm happy to try and answer kind of off the cuff here. You can either put them in the chat or unmute yourself and pop your video on and say hi.
Hello. Hello.
Hi. Far away.
Thank you very much for your input. Yeah, I really appreciate it. But I have a question. Please, can you repeat the outcomes? What you said about the outcomes?
Yes. What I will also do with the outcomes is I've got a very good resource somewhere for understanding it's better than I've explained it, and I'll give it to Theo to circulate to everyone. So if you have a systematic review looking at one outcome, so if you're, for example, looking at, I realize I may have not explained it that well. If you have a systematic review looking at one outcome, for example, does giving aspirin reduce your mortality at 1 year, for example, and you're systematically reviewing the literature and you're looking at that one specific outcome, then you will find a difference either way, or you may not find a difference. If you are looking at multiple comparisons, if you're looking at multiple comparisons, you're more likely to find a difference just by chance. So this, again, more applies to randomized controlled trials. If you are looking at randomized trials that have multiple secondary outcomes, the trials are not powered for those secondary outcomes. So to power a randomized trial, which is the method which so the power of a trial is its ability to basically find a significant difference if there is one. And to do that, you need to have an appropriate number of patients in each arm for your trial. So you need to have a big enough number of patients that when you compare the two, you'll find a difference if it's there. But the trial is always powered from the primary outcome. So let's use aspirin again. So the primary outcome will be looking at 12-month mortality in the if you give aspirin or don't give aspirin. So you'll have a number of, your trial will be powered to have X number of patients in arm A receiving aspirin and X number of patients in arm B. And they'll say, with this many patients, we should see a difference if there is one. And that will show us our primary outcome. However, if you've got lots of secondary outcomes, so they're saying we'll also look at the number of patients having, I don't know, nosebleeds or bleeding from elsewhere or chest infections or allergies or whatever it might be, because the trial is not powered for the secondary outcomes, you might find that you've got more patients needed. You've got more patients than you need to find a difference, or you might not have enough patients to find a significant difference in the secondary outcomes. And so your chance of having, if you have lots and lots and lots of secondary outcomes, because the trials are not powered for those, you might incidentally find that you have a difference where there isn't one. And so if you then do a systematic review looking at a trial and include trials that have lots of secondary outcomes, you're more likely to find a positive result for one arm of your trial and therefore your systematic review when actually there isn't one there. So good trials will have a very well-defined primary outcome, and they will have a few key secondary outcomes, but not whole rafts of them. Does that make more sense?
Yes, please. Thank you very much.
Pleasure. Any other questions, guys?
I mean, if you have a question, you can just unmute and then just ask the question.
There's just a couple in the chat. Let me just pick up in the chat. That's a good question. So someone's put a very good question. So when I was talking about implementation of the results for systematic review, I said one method might be that rather than, if you've got a new treatment and there's a systematic review that says the evidence suggests that treatment A is better than treatment B, we're talking about the implementation of that. And we're saying that it might be better to, rather than saying, well, we'll suddenly start using this treatment for all of our patients, it might be that you say, we'll just try with a few patients, and if everything goes well and we're happy that it's safe in our unit, then we can expand to a wider population. So it's not a formal randomized controlled trial, but it's just using some of your patients, just allowing some of your patients to have the treatment. And then if you're happy with the outcomes in your patient population, then you can kind of roll it out into the wider population you look after. So for example, if you had, if there was a new surgery, for example, that you wanted to do to remove a tumor from somewhere, but it was quite a big surgery, you might find that the systematic review says the outcomes for this type of operation are much better in terms of you get much better cancer, you get much better resection margins, and it's better at removing all the cancer. Well, that's great, but you may not want to do that for every patient. So you might start off with a few of the younger, fitter patients you might trial it with. And if you find that it's safe in those patients and that you as a unit can provide that service safely, that you then start increasing the age of the patients you give it to, and you kind of look at the safety profile in your unit. I hope that makes more sense. Does anyone else want to unmute and ask a question? I don't think I've missed anything else in the chat.
Yeah, someone has sent me a question.
Far away.
Yeah, someone is asking. They got confused with searching principle. I think in the video, someone mentioned it was mentioned control vocabulary and hand searching.
Yes.
And I think there was a question about that.
I think I've got that here, and I didn't touch on that. It's a good point. So controlled vocabulary and hand searching are two different techniques. So controlled vocabulary are where you use a specific set of search terms to challenge a search engine. So let's take PubMed, for example. If you wanted to know about kind of the role of, I don't know, aspirin and heart attacks and then mortality. So if you wanted to know the number of patients who have a heart attack and then have aspirin, you want to know what their mortality is. Does giving aspirin reduce their mortality? You would have a very controlled set of vocabulary. So you'd be looking at, you'd want to define vocabulary for heart attack. You'd want to define vocabulary for aspirin, and you'd want to define vocabulary for mortality. And so you'd have a combination of different search terms that would include everything that could possibly be interpreted as a heart attack, everything that could be interpreted as mortality, and everything that could be interpreted as aspirin. And you'd search those together, and that should bring up everything in the literature relevant to that, basically. So that's the principle of using controlled vocabularies. You set a specific set of search terms and you put them into your search engine, and it should give you back everything on the topic that you've searched. Hand searching is where you physically go through a journal and you pick out the studies that you want. So for example, I'm doing one of those at the moment, and it's we're looking at randomized controlled trials of interventional procedures that have a co-primary outcome. So there are no real ways of me searching that, in that if I was to try and look at randomized controlled trial, co-primary outcome, and interventional randomized controlled trial, because that would, so if I use that as controlled vocabulary, it's not going to bring up necessarily all of the randomized controls that I want. It may bring me up more articles on trial methodology, but it may not bring me up trials on interventional procedures, because trials don't always say randomized controlled trial of this intervention. They might say, for example, a randomized trial of, I don't know, of NG tube placement after major abdominal surgery. So there's an invasive procedure, but they've not specified that in the title. And so when I put in my controlled vocabulary, it won't pick out that trial. But by doing a hand search, it allows me to go through the journal and identify those trials that I think are relevant to my search question. So I would say if you're looking to do a systematic review, looking at the methodology behind things, so methodology behind studies or methodology behind randomized controlled trials, or to assess different systematic reviews. If you wanted to do a systematic review of systematic reviews, for example, then you're better off doing a hand search and going through the journals and picking out those that are relevant, because your controlled vocabulary would not pick up those articles. I hope that makes more sense. But on the whole, hand searching is not really used very often at all. You should usually be able to answer your question with your controlled vocabulary. So you identify your search terms and then you put those into your search engine.
Yeah. In addition to that, Harry, thank you for mentioning that. In addition to that, in the at least in the medical field, we have what we call the medical subject headings or mesh terms, and these are like also very controlled, organized vocabulary that's produced by I think the National Library of Medicine in the US. Now, the usefulness of the mesh terms, that's the medical subject headings, is that, for instance, if you were doing, let's say, a search or a systematic review on something, say, let's say cancer, there are other relevant literatures that may not say cancer. They might say neoplasm, or they might say tumor, or they might say tumor with the spelling of a U, or tumor with the spelling without a U. But then when you use a mesh term, it captures all these words so that you don't miss any article that mentions them. I hope that makes sense. So in your search, you would want to include mesh words so that you don't miss very important articles to your systematic review.
Very wise words, Theo. Very wise words.
There's another question. Please, during the literature review, we were advised to save all websites and articles used in the review. What would happen if you included a reference link that you didn't actually use that is related to your topic? I don't understand this question.
Yeah. What would happen if you included a reference link that you didn't use but is related to your topic? Thomas, could you maybe unmute and tell us a bit more about your question? Because I think I'm almost there. I just need a bit of prompting in the right direction.
Hello, Thomas.
Okay, hello. Yep. Okay, please, I'm asking, during the course on Coursera, we're advised to save all the websites that we cite information from or use in our literature review. But what will happen, or is it wrong, very wrong to, maybe you didn't save all the websites, so you include a reference in your literature review that you actually didn't use the information from that article. So is it wrong? You have to go through all the references and know that you used information from every one of the references you've listed.
So is your question? So firstly, thank you for clarifying. So just to check, so your question is, if you save your websites and the articles and you go through all of them, but you don't use the data from one of the articles that you've saved. Is that what you're saying?
Yes, please, exactly.
So it's a good question. So you're so for a systematic review, the systematic process is to identify the relevant papers. You might find that you have a question, you get your articles, and you have 5 papers at the end of it. Now, when you look through those papers, you might find, as you say, that they are relevant to your topic, that they meet your inclusion criteria and they meet your exclusion criteria, for example. But actually the data in there doesn't quite meet the topic, or doesn't quite answer the question you want to answer. So for example, I don't know, if you wanted to look at, again, treatment A versus treatment B, and you wanted to look at a specific population of patients, let's say, I don't know, 18 to 25-year-olds, and actually the paper that you got reported the outcomes for patients from 18 to 80 years old, you can't use that paper or the data because you can't separate out the patient population that you want. And that's okay, but that means you then exclude that paper. So you wouldn't include it. So if you get to a point where you've done your nice systematic, you've triaged your abstracts, you've got the papers you think you want left, and you find that actually you can't use the data in them, that's okay. They go on the exclude pile. And so you wouldn't include those in the final data synthesis of your review, but you'd still include them in the Prisma flowchart that you'd create. Does that answer your question?
Yeah, and in addition to that, any paper that you exclude, it's usually useful to write or note down the reason why you've excluded that paper, so that you add that to your methodology or your results, sorry, to say exactly why you excluded these papers from the final papers you used for your systematic review. Because sometimes you might be asked at peer review reasons why you excluded these number of papers from your article. So and if you haven't done that, it's difficult now to go back and then relook at 65 or 100 papers and see why you excluded them.
So to help with that, Theo's absolutely right. It's really useful to be able to do that. So one piece of software that I find extremely useful is, I'm just trying to log into it now. Perfect, it's working. That makes a nice change. Let me just share my screen with you guys. So there is a software called Ryan. I don't know if you've come across it before. So RAYAN.ai. So it's a free software to use. And once you've done your searches and you've got all of your articles downloaded from your websites, whether you've put them into EndNote or into a kind of Google Drive, whatever it might be, it has very clear instructions on the main page about how you can upload them onto Ryan. And essentially, when you do your triaging of all of your abstracts, when you click on one of them, it will allow you to see the title and the abstract, and then it gives you an option to include and exclude. And at that point, so you can see the ones in red here, for example, you can click and you can either use the labels that they've already given you, or you can add your new one, for example. So I might say, I don't know, whatever your reason is, you add in your reason, okay? And it then labels your paper as excluded for this reason. So for example, in this one, I've excluded this one because it doesn't describe the disease that I was looking at, okay? And then when it comes to doing your Prisma diagram and understanding those reasons at the end, I know how many of each thing have been excluded and what the label is and why. So exactly as Theo says, good methodology is to be able to say, I've excluded this many articles for this reason, this many articles for this reason. And when you look at your Prisma flow diagram, again, you can give reasons at this point. So as part of your Prisma diagram, you'll be able to include, or you'll be able to give reasons for why you've excluded articles and the number you've excluded. So I would highly recommend using Ryan as part of your work. It's made my life much easier, much easier.
Thanks for touching on this, Harry, because I think eventually that's the software we're going to use for our reviews, because it's free. Most of the others would need to pay for it or subscribe in a certain way. So I think everyone should note Ryan down and then start getting familiar with it, because I think that's the easiest way to get through this systematic review. You know, actually, when I did mine, I did not I did not use the reasons. So I just went quickly and then just excluded, added, subtracted maybe, and then finished and had like about 500 plus excluded papers. And I didn't know which reasons why I excluded them, which was really, really very painful. So
I did exactly the same thing. And yeah, it's worth starting doing it from the word go. Otherwise, as Theo says, it's a very painful process going back through all of them again. Okay, where did we get to? So we've answered Thomas's question. So another good question. So after picking the words and terms with the help of your mesh and picking your mesh terms, how do we formulate what we should type in the search bar? Good question. So this is something that you will pick up mainly through practice. Okay, so you will find that what you want to do is have a complete set of vocabulary that will allow you to look at one specific thing. So for example, if it was cancer or colorectal cancer, let's take colorectal cancer. To look at just colorectal cancer, there'll be a mesh term for colorectal cancer, which I believe is termed colorectal neoplasm. And within that heading, it has colorectal cancer, rectal cancer, colon cancer, everything under there. So that would be your mesh term. And if you then wanted to look at, I don't know, a particular type of surgery, let's say a hemicolectomy, half the bowel being taken out, you wanted to look at colorectal cancer and hemicolectomy, you then write "and" in between the two. So you have one set of vocab and another set of vocab. Sometimes you might want to do something more specific and have your mesh term, such as colorectal cancer, and you might want to add in something else. So you might want to do colorectal cancer and a metastasis, for example. Theo's just very helpfully put the link in the chat for how to find your mesh terms. So if you wanted to include two mesh terms together, for example, so you want to look at colorectal cancer as a mesh term to give you everything to do with colorectal cancer, and then you wanted to look at metastases, so colorectal cancer metastases, you then use metastasis as your mesh term, and that would give you everything to do with metastasis. So you could then put them both in brackets. So you'd have open bracket colorectal cancer and metastasis, close bracket. And within that, that will give you every single thing on PubMed to do with colorectal cancer and metastases together. Then you can do "and" hemicolectomy after that. So the best way to do it is to play around a little bit. So to identify your mesh terms, identify the vocabulary you want, and then you can play around with adding things like "and" or in between to see what your results come out as. It's quite hard to verbalize and to explain on here. So my advice would be, if you go onto PubMed and look at the advanced search function, and it gives you a bit of guidance on how to do it, and just have a play around with something simple. Jonathan has asked a good question about, can I elaborate more on the estimate of effect and weighted average in meta-analyses, and more specifically how the calculations are done? So the honest answer, Jonathan, is no, because statistics go well over my head, okay, and I won't pretend to know much about them on this front. However, when you do these, there are softwares that will do it for you. So the software that you probably would have heard of is RevMan, which I will send a link to in the chat. And with RevMan, you can set the weighted average, and you set your estimates of effect. You plug in your data and you click go, and it will do all the calculations for you. So you're not expected to do long, endless sums and complex maths. The softwares now that are out there will allow you to plug in your data, pick a few variables, and you literally click go, and it brings up your forest plot for you. Hence, I don't know much about the statistics because I've never really had to learn, but that will be helpful for you. And then next question, what are the cost implications of having to own the papers used for the review unless it's possible to take a review? That's a very, very good question, Festus. So there will be some papers out there that you have to pay for to get hold of. And that can be really limiting because none of us have, if you've got 400 papers to look through and it's £30 a paper, you can't do it. So what I would say is use this website here. So if you're affiliated with a university, for example, sometimes the universities have subscriptions to journals. Otherwise, the link that I've just put in the chat is a slightly underhand link. Okay, so it's basically a link that allows you to copy the DOI of a journal or of an article. You copy it into there and you click go, and it will bring up the paper. Okay, it's a PhD student from Russia, I believe she is, that she's created the link that basically bypasses the payment schedule or system and allows you to get the paper for free. So you're right, sometimes the cost can be very limiting, but I would try everything you can to get round having to pay for your papers, and that link will be of some help to you. So I hope that helps, Festus. And Theo does qualitative synthesis in systematic review mean anything different from discussion of results? That's a good
So
question.
this was sent to me privately by someone.
So if you've done a qualitative systematic review, so if you've looked at qualitative data, then that is your results. So if you've looked at a systematic review of people's opinions on something or experiences of something, got no quantitative hard number data, if you've done a qualitative review, then that does become your results section. And then you will discuss it in your discussion as well. For me, the qualitative synthesis is merely a description of the papers that you've got. So I put it at the front of my results and say, I've got this number of papers covering this number of patients with from this many places, for example. And then I go into my results section and then can discuss it further down. Again, if you look at the PRISMA guidelines, the PRISMA checklist, it gives you a very clear system for how they want the results presented, so you know where everything fits into your results and into your discussion. That's where I would signpost you for that. I don't know if you've got anything to add to that one, Theo.
I think you've just said it. The PRISMA guidelines, especially the article you put up, was very, very, very immensely helpful to me. The first time I attempted a systematic review, just went step by step by every single topic they said. Of course, some of the things may not apply to your particular work, but then it's useful at the end of the day to go through what they've said. Because if you do that, actually, it will be easier for you when it gets to the point where you register it on Prospero, because they've covered every single topic that Prospero would ask you to inputting. So.
Yeah, absolutely right. So I've just put the link for the PRISMA guidelines. So on the website, it's in the top right corner. It's called the PRISMA checklist, and it gives you a whole table of things that need to be in your introduction, your methodology, your results, and then your discussion. And it's very straightforward to follow through. And as Theo says, it reflects the protocol that you'd have written before your systematic review as well. And then Jonathan has asked, can we talk about various domains of the assessment of the risk of bias? In the course, they were comparing various papers using certain parameters. Good question, Jonathan. So I won't go into the kind of fine details, but essentially there are different tools that you can use to assess the risk of bias in a paper. And the tools you will use will depend on whether you're looking at a cohort study or a randomized controlled trial, for example. And they will basically, the tools are, they test the methodology of the study you're looking at. So they look at how robust the methodology is of the study that you might be including in your systematic review. So if the study has a very high chance of bias because their methodology is very poor, then it might give you a result that you don't completely trust or you don't want to put too much faith into. And so if you're systematically reviewing something and it turns out that, let's say you're looking at two treatments, treatment A and treatment B, and treatment A comes out on top, it's important to know that the studies that have proven treatment A is better have a very robust methodology. Because if they don't, then it may be that actually something's gone wrong and treatment A is not really as good as it sounds, and your systematic review has wrongly concluded that. So the risk of bias tools will look at various bits of the methodology. And again, it will depend on what you're looking at as to which tool you use. So usually you can use the Newcastle here. Let me find the links. Give me 1 second. I'll pop these all in the chat. So the Newcastle Ottawa score is quite useful. So that's one I've just put up now. That's useful for non-randomized studies. And if you've got a randomized control trial, you can use the Cochrane's ROB2 score. So those two are the ones that you'll kind of most likely be seeing. But again, so they test the, sorry, I've not put them in the chat. I've sent one very lucky person a private message by accident. Give me a second. So this one. And this one. So those are the tools. And again, they just test the methodology of the studies that you're using in your systematic review to make sure that your systematic review itself isn't biased by the studies you've used. I hope that makes more sense now. Mingo has said, if your area of research is new and there are not many publications on that area, is it possible to do a systematic review? The answer is yes, you can do. As I said, you may have missed it a bit earlier. So if you've got a very niche topic or a very new topic, there may not be much out there, as you said. So it may be better to do a systematic scoping review. And the point of a scoping review is to acknowledge that there's not much out there and say we haven't got a huge amount of data, but here it is. This is the data that we do have. So that allows you to systematically review the data you have for something that does not have much data out there. And again, I can find you there. It's on the slides and I will send you. That is. Bear with me 1 second. Yeah, so it's now in the chat. So that's the paper with the guidelines for you what a scoping review is and how to use it, and it gives you a nice checklist of what to do. And again, it's on the Prisma website. I hope that answers your question. So there's not much data out there, it's very new. Think about maybe doing a scoping review, for example.
Yeah, and also if you couldn't do a scoping review and you went ahead and did a systematic review anyways, and after your systematic search you find no studies, it is still a systematic review and it is worth publishing. It's just it's still an evidence showing that there's no rigor evidence, or at least you couldn't find it following a systematic process. So actually what makes it a systematic review is the systematic process you went through, and not necessarily the number of included studies in your final report. I don't know if that makes sense. All right. Any other questions? I think we are almost, we're a little bit past an hour. If there are no other questions, I might just say a couple of things. First of all, Harry, thank you very much, mate. Thank you. He's just finished a string of nights, and then he still took the time with interesting patience, and he still took the time to actually come and do this. Thank you very much, Harry.
No, thank you very much for having me. And it's exciting to see so many of you kind of here, and I wish you all the best in the future with the systematic reviews you'll do.
Yeah, and Harry would take I think charge of one group, isn't it, Harry?
Yes.
Yes. So hopefully one lucky group will be seeing Harry again. Yeah, I just wanted to, Dorcas, is it possible for me to share my screen? Yeah, I think I can share my screen. So I just came across this in my email, which is actually, I thought was very good, especially for whatever topic you wanted to do. If you were, lost for ideas, this I think you can research something like this. It will give you ideas as to the things that need researching. That's the first thing. And then the second thing is, we are at this point in systematic review, and hopefully we'll be going through this as the days go by. We are going to add every single one of you on the pages to this sheet, and then we would record exactly what each individual does as the days and weeks go by. So just watch out for this. If there is no other question, Harry, thank you very much.
Pleasure. Thanks, guys. Thanks very much, Theo. And I look forward to catching up with you all soon.
Yeah, Harry, see you tomorrow. Are you at work tomorrow?
Yes.
No, you're off.
No, I'm off. I'm not in. I'm coming in on Thursday. I'll see you Thursday.
Okay, I'll see you on Thursday.
All right.
Thank you very much.
Bye.
All right. Thank you, everyone.